At the outset, I would like to thank Dr. Bansi for inviting us here. Respected chairpersons, the topic which is very common one, how to manage diabetic kidney disease particularly. All physicians here might be treating and seeing the patients which are going for a dialysis. Because we know that once the diabetes starts, nephropathy already has been started. So some or other day these patients are going for a diabetic nephropathy, stage 3 or stage 4 kidney diseases or end stage renal diseases. So these patients are likely to go for dialysis. And how to manage the dialysis patients for hyperglycemia is a challenging job, and it requires efforts from everyone, including dietitians, treating physicians, and the nephrologists. So to keeping in this mind, and the most important thing in diabetic kidney disease, those patients who are undergoing dialysis is mainly hypoglycemia. And we know that one incidence of hypoglycemia, how much burden it costs, it previously already one speaker has told us. So the important thing is that this is the case which has been discussed. This is a 58-year-old male. We see such type of cases in day-to-day practice. Type 2 diabetes on maintenance hemodialysis for 3 times a week, and duration of the dialysis is almost last 6 months. This patient is on insulin glargine. So we are supposed to keep these patients only on insulin. We have to stop all oral anti-diabetic drugs. Then insulin glucine, this patient was on short-acting insulin. There is a history of previous post-dialysis hypoglycemia, which is very common in these patients. And HbA1c, how much HbA1c is reliable in diabetic kidney disease? Everyone of us know that. So HbA1c of 6.4%, with symptomatic fluctuations. So we see a lot of hyper and hypoglycemia in this patient. What is the concern in this patient is, because we know that diabetic kidney disease patients' appetite is poor one, these patients are going for progressive sarcopenia, and there is a glycemic variability. So we know that 30 to 40% of the patients who are undergoing dialysis, they are diabetic. Why these patients are to be treated with dialysis? Because these are the patients who are going to increase almost double cardiovascular risk than any other patients, and hospitalized risk is almost 3 times. So diabetes mellitus represents one of the most common comorbidity in the dialysis population worldwide, and the poor glycemic control double the risk of cardiovascular events in dialysis patients as well as in non-dialytic patients also. And diabetic patients faces significantly higher rates of hospital admissions because of repeated hypoglycemia also. And diabetes mellitus stands as the leading cause of the end-stage renal disease. So what are the pathophysiology in diabetic patients is mainly the altered insulin metabolism in these patients. The altered insulin clearance, there is because of altered insulin clearance, there are chances of hypoglycemia. The drug pharmacokinetics is also changed, so we have to stop all oral anti-diabetic drugs in these patients. Because altered pharmacokinetics of oral anti-diabetic agents require careful dose management. Then there is the dialytic glucose loss. Once the patient is on dialysis, there is a glucose removal during the hemodialysis session. It can precipitate hypoglycemia. And there is uremic toxicity, which causes increase in insulin resistance. Then there is autonomic dysfunction, which causes compromised autonomic dysfunction, blunts the signs of hypoglycemia. HbA1c fluctuations. So we know that HbA1c is not a reliable criteria in these patients. So we have to find out certain other things to find out how much is the diabetes controlled. There is altered red cell blood cell lifespan. There is chronic kidney disease significantly reduces the RBC survival. We all of us know that. Then there is erythropoietic stimulating agents, which causes artificially lowers HbA1c levels. And there is a frequent blood loss during dialysis, which causes regular blood sampling, and dialysis associated with losses contributes to the hemoglobin glycation pattern. So HbA1cs are not a reliable thing in these patients. And then carbamylated hemoglobin interferes with the uremic toxins, cause carbamylation of hemoglobin, which can cause seriously elevate HbA1c measurements. So what is the clinical pulse in this patient is HbA1c alone is misleading in dialysis patients. So what are the alternative glycemic markers other than HbA1c? These are glycated albumin, but it gives control for last 2-3 weeks only. Then another is the fructosamine, which also is important, which causes gives the idea of short-term glycemic control. Then there is continuous glucose monitoring, which is very important in these patients, and the self-glucose monitoring is also important. So CGM insights in the dialysis population reveals significant day-to-day glycemic variability. It detects frequent post-dialysis hypoglycemia. Here also the important thing is CGM data frequently reveals a glycemic gap. So these are where you should control tight blood sugar HbA1c levels. These are the patients where you can have more stringent and less stringent criteria. Then what are the oral anti-diabetic drugs which can be used in end-stage renal disorders? These are metformin is contraindicated. Sulfonylureas, they are high risk. There are only certain sulfonylureas which can be used in lower doses. Then meglitinides, unpredictable. DP4 inhibitors, generally they are safe, but certain DP4 inhibitors you have to use in reduced doses. Then pioglitazone you have to avoid because of retention. Then SGLT2 inhibitors are not effective in end-stage renal disease because their mechanism of action is it is excreted through the kidneys. So these are the drugs which can be used and which cannot be used. Insulin is the most cornerstone in the treatment of these patients. Other drugs which cannot be used, most of them are not used. It is only insulin and insulin which is to be used in these patients mainly. So what are the, this is insulin, the mainstay therapy, how it can be used? Because of reduced clearance, decrease in insulin clearance leads to prolonged insulin action and increased duration of glucose lowering effects in dialysis patients. So when you are using insulin, that time also you have to see for the hypoglycemia. Then insulin adjustment principles, I will not go into the details because of the time constraint. So dialysis day considerations are very important. The physiological changes which seen when the patient is ongoing dialysis, glucose removed during dialysis, which may cause hypoglycemia. The timing consideration of the dialysis is also important, where we are supposed to give insulin. Then clinical strategy of this patient is insulin dosing should be individualized for each dialysis session based on timing, duration, and patient's typical response. So each dialysis session presents unique challenges for monitoring the glucose, avoiding hypoglycemia. It is not only the physician who is important in treating these patients. Specialized dietitian care is also important. The patients' meal timings are also important to give the insulin. Then protein energy conservation, 1 or 2 minutes. So these are what are the challenges? One is misleading HbA1c. CGM reveals truth. Nocturnal hypoglycemia is very common in these patients. Then post-dialysis syndrome and inappropriate regimens. So these are the stepwise management programs, how you can implement. Then this is about we know the stages of the kidney disease depending on the GFR and the albuminuria categories. Then this is the critical complications which are likely to occur in these patients. So these are the emerging therapeutic approaches. GLP-1 receptor agonists are likely to come in for these patients. Then closed loop systems, ultra short acting insulin, CGM driven algorithm is important, and this is how much you can get a success with the CGMs. So take home message in this patient is HbA1c is limited one. Insulin is the first line of treatment. Hypoglycemia prevention is the most important thing in these patients. There are the dialysis specific adjustments of the insulin are required. Multidisciplinary approach is required in these patients. Thank you very much.